Tachyarrhythmias are abnormal heart rhythms with a ventricular rate of 100 or more beats per minute. These rhythms are classified as either narrow or wide complex tachycardia with further subdivision into regular or irregular rhythm. Tachyarrhythmias can be categorized as narrow complex or wide complex. Narrow complex tachyarrhythmias include sinus tachycardia, atrial flutter, supraventricular tachycardia, SVT, and atrial fibrillation. These arrhythmias usually originate above the ventricles in the atria or AV node and run normally through the bundle branches, producing a normal QRS complex. Wide complex tachyarrhythmias originate in the ventricles and include monomorphic and polymorphic ventricular tachycardia, torsades de pointes, a form of polymorphic ventricular tachycardia, and ventricular fibrillation. Supraventricular tachycardia with aberrant conduction can also produce a wide complex tachyarrhythmia. Sinus tachycardia, the most common tachyarrhythmia, is identical to normal sinus rhythm, except the rate is between 100 and 150 beats per minute. Sinus tachycardia is a normal physiologic response when the body is under stress, such as that caused by exercise, illness, or pain. It may also be seen in patients with heart failure, lung disease, shock, or hyperthyroidism. Atrial flutter is caused by an ectopic focus in the atria that causes the atria to contract at a rate of 250 to 350 beats per minute. The underlying mechanism of atrial flutter is most often a reentrant circuit that encircles the tricuspid valve annulus. Supraventricular tachycardia, SVT, is an arrhythmia originating above the ventricles. In general, the rate is greater than 150 beats per minute, which helps to differentiate SVT from sinus tachycardia. SVT can be classified as AV nodal reentrant tachycardia, AV reciprocating causes tachycardia and atrial tachycardia. Atrial fibrillation is caused by multiple ectopic foci in the atria that cause the atria to contract at a rate of 350 to 600 beats per minute. Rarely, the atrial rate may be as high as 700 beats per minute. The AV node only allows some of the impulses to pass through to the ventricles, generating an irregular rhythm that is completely chaotic and unpredictable. Ventricular tachycardia occurs when a ventricular focus below the bundle of His becomes the new pacemaker. The ventricles contract rapidly, usually at a rate faster than 100 beats per minute, and usually with a regular rhythm. The rapid ventricular rate significantly diminishes cardiac output and can only be sustained for a short period before the patient becomes hemodynamically compromised. Ventricular tachycardia can quickly turn into ventricular fibrillation, leading to cardiac arrest. Torsades de pointes is a highly unstable form of polymorphic ventricular tachycardia that may revert to sinus rhythm or degenerate into pulseless ventricular tachycardia or ventricular fibrillation. The patient's appearance on rapid assessment can vary widely depending on the arrhythmia. The patient may appear to be in minimal distress, show signs of hemodynamic compromise, for example, pale, mottled, or cyanotic skin, or show signs related to the underlying cause of the arrhythmia, for example, pain, diaphoresis. Conduct a primary assessment following the ABCD approach and provide care as needed. Obtain and monitor the patient's vital signs. Establish cardiac monitoring, pulse oximetry, and vascular access, and be prepared to provide CPR and defibrillation if the patient's condition deteriorates. Provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of at least 94% to 99% and provide assistance with ventilation if needed. Assess level of consciousness in patients who appear to have changes in mental status. Obtain a 12-lead ECG if time and resources permit. The goals of the secondary assessment are to identify signs and symptoms and determine whether they are being caused by the arrhythmia or another condition. Further determine the severity of the signs and symptoms. Identify the arrhythmia, if not done as part of the primary assessment. Identify potentially reversible causes of the arrhythmia. When tachyarrhythmia is suspected, the team takes actions to ensure adequate airway, breathing, and circulation, including obtaining and monitoring vital signs, establishing cardiac monitoring and pulse oximetry, administering supplemental oxygen if needed, and ensuring vascular access. If time and resources permit, a 12-lead ECG should be obtained. When a patient is found to have tachyarrhythmia with a pulse, take a 3-step approach to determining appropriate care. Next, if the patient's heart rate is greater than 150 beats per minute and the tachycardia is not presumed to be sinus tachycardia, determine whether the patient has adequate perfusion or is hemodynamically compromised. Finally, if the patient's heart rate is greater than 150 beats per minute, the tachycardia is not presumed to be sinus tachycardia, and the patient is not showing signs of hemodynamic compromise. Determine whether the QRS complexes are narrow, less than 0.12 second, or wide, equal or more than 0.12 second. If the patient's heart rate is between 100 and 150 beats per minute, and the patient is not showing signs of hemodynamic compromise, the patient's condition should be monitored. For example, cardiac monitoring, non-invasive blood pressure, monitoring vital signs. A 12-lead ECG may be obtained, and an effort should be made to identify and address the underlying cause of the tachycardia. When a patient with tachyarrhythmia with a pulse has signs of hemodynamic compromise, synchronized cardioversion is indicated. If the patient's condition allows, administer sedation before initiating cardioversion. Follow the device manufacturer's recommendations for energy doses. Consider adenosine, 6 mg via rapid IV push followed by a rapid 10 to 20 mmol normal saline flush before synchronized cardioversion for a narrow complex regular rhythm if vascular access is readily available. Do not delay cardioversion to administer adenosine. If the patient is not showing signs of hemodynamic compromise, the QRS complex is narrow and the rhythm is regular, attempt vagal maneuvers to break the tachyarrhythmia. Consider adenosine, 6 mg via rapid IV push followed by a 10 to 20 ml normal saline flush if the rhythm is regular. An additional 12 mg dose of adenosine, followed by a normal saline flush, may be given if the rhythm does not convert. Consider a calcium channel blocker or B blocker if the rhythm is not regular, adenosine is ineffective, or the tachyarrhythmia recurs. Consider expert consultation. If the rhythm is wide, QRS complex more than or equal to 0.12 second, regular and monomorphic, and the patient does not have signs of hemodynamic compromise, the rhythm may be supraventricular tachycardia with aberrant conduction. In this case, consider adenosine, 6 mg via rapid IV push followed by a 10 to 20 ml normal saline flush. For a patient without signs of hemodynamic compromise and a wide rhythm, consider an antiarrhythmic medication, procainamide, amiodarone, or sotalol. Procainamide, avoid in patients with known prolonged QT intervals or congestive heart failure. Administer 20 to 50 milligrams per minute until the arrhythmia is suppressed, hypotension develops, the QRS duration increases by more than 50%, or a maximum dose of 17 milligrams per kilogram is given. The maintenance infusion is 1 to 4 milligrams per minute. Amiodarone, administer 150 milligrams over 10 minutes. Repeat as needed if the tachyarrhythmia recurs. The maintenance infusion is 1 milligram per minute for the first 6 hours. Sotalol, avoid in patients with known prolonged QT intervals. Administer 100 milligrams, 1.5 milligrams per kilogram, over 5 minutes. When a patient with wide complex ventricular tachyarrhythmia with a pulse has signs of hemodynamic compromise, synchronized cardioversion is indicated.